Our last speaker is Melissa Hallett. Melissa is a physical therapist who specializes in the treatment of pelvic floor dysfunction and breast cancer rehabilitation and is owner of Hallett Physical Therapy in Mashpee. Melissa completed a master's program in physical therapy from Notre Dame College in Manchester, New Hampshire, and earned her doctorate of physical therapy from Franklin Pierce University in New Hampshire. Melissa has extensive training in women's health rehabilitation and is currently seeking a certificate of achievement in pelvic PT from the American Physical Therapy Association. She began practicing physical therapy for Cape Cod Hospital in 2002 as a women's health specialist. Today, Melissa will discuss the pelvic floor. You're in control. Melissa?
Am I on? Okay, cool. Thanks, Julie. This is such an amazing venue. I had no idea about these. I wasn't a patient of Emerald Physicians. Well, I was a long time ago. Took a break, and now I'm back. So getting the emails about this wellness trail is amazing. And as my husband will tell you, is the only man in the room. Thanks. I love to talk about this topic, and I will talk to anybody and literally anywhere. But it's usually one-on-one, so getting to talk to all of these women at the same time is amazing. I was going to tell you about me because I didn't know that Julie would, so thanks for doing that. So I have been doing this for quite a while. Since 2002, I was working at Cape Cod Hospital, and at that time, pretty much the only one around doing this kind of treatment, working with pelvic pain, urinary incontinence. We did a lot of prenatal stuff. Postpartum rehab, and then I took a long break having my own kids and deciding that working for the hospital in those hours were not really conducive to being home for my own kids. I took a break and then started really hearing again, like, this is something that, no one jumped in and no one took my place. So they were, a lot of my colleagues were saying, we really were getting a lot of referrals for this and we really need you to come back. And couldn't really go back to the hospital, but decided a couple years ago that maybe going out on my own was a thing to do. So that's what I do. Let's not talk about that yet. So show of hands, or maybe you don't want your friends next to you to really know what's going on with your body, but how many of you are leaking when you cough, sneeze, jump, exercise? Yeah, I thought so. How many of you are starting to feel more like vaginal pressure or anything pelvic going on, taking a shower, cleaning yourself, being like, there's something that wasn't there before. Again, we need to be in tune to what's going on in our bodies, just like we're talking about breast health, to know the changes that we find everywhere. So these are really private things that go on with women, and a lot of us don't talk to each other. Sometimes if we have a male doctor, we're not talking to him about it. Even if you have a female doctor, sometimes it's like, well, this is just normal. This is what's going to happen. So I'm just going to deal with it. But it's 2018, and when I went back to practice last year, 15 years later, I'm still finding that no one's talking about it. And it's shocking to me, maybe because I'm on the younger side and we talk about a lot of things. But I feel like the more we talk about it, the more we can get things done, because you're really in control of a lot of these symptoms and a lot of things you can take control of if you start talking about it. And a lot of it has to do with the pelvic floor. So what are the pelvic floor muscles? We kind of group them all together. They're very small muscles, obviously, inside the pelvis, and you can't really activate them all individually, so we talk about them as a group. They're basically 3 layers of muscle and connective tissue that go from, this is a side view, where's my thingy? So from, it doesn't much matter, from front to back, so from your pelvic bone to your coccyx, and from side to side. So it sort of forms a sling, kind of front to back and side to side in the hips. And they serve multiple functions. They do a lot of things. So first thing they do is they're in control of continence. When the muscles contract, they close off the anus, the vagina, and the urethra all together. And so they assist in urinary and fecal incontinence. And they also support the pelvic floor structures. So all your organs, your nerves, your vessels, your fascia. And they provide stability and postural support. So we also, as therapists, when we're talking about the pelvic floor, we also do an assessment of your abdominal muscles, your back muscles, just to make sure that everything is kind of working in sync together. You also have to coordinate these muscles with respiration so that everything's working properly, and they also play a role in sexual function, but that's another presentation altogether, which I'd be happy to give. So I'll try to be brief with this because it can be a little bit heavy, I guess, in the anatomy. But there's three different layers. So the first layer is for sexual function. I don't know if I can really point this exactly, but this is the first layer right there. And so we're not really going to talk about how those muscles work and what they function. But the middle layer is the perineal membrane, which is like a fibrous muscular tissue that spans the whole pelvic outlet. So all of those from front to back and side to side. And that's basically just supportive to the pelvic floor. And it also assists in urethral closure, so to help with that continence. The third layer is the pelvic diaphragm, and that's where we basically talk about the pelvic floor muscles. So the levator ani and the coccygeus muscles. And again, they're all little muscles, but we group them all together. And those are critical in the support of the pelvic floor. They're generally in a constant state of support, because if they weren't, the muscles would be not active and things would just start being super dysfunctional. So the muscles can be voluntarily contracted, and I'm sure you've heard of the Kegel exercise. That's when you voluntarily contract your pelvic floor muscles. And so full relaxation of the muscles should only happen with defecation, with voiding, and childbirth. That's when your muscles should be completely at their most relaxed state. But it's not only important that you contract the muscles, you also have to relax them. So the bladder, it's a muscle controlled by the brain. And in the most simplest terms, you control your bladder. It's a very complex system, but it all starts with the feeling, the fullness in the bladder. So let's see if we can make it a little easier. So basically, your bladder fills up. It sends an impulse. The bladder says, okay, we're getting full. Sends an impulse up the spinal cord to the brain. The brain says, oh, time to go. And you make a conscious decision whether you're going to go or not. Obviously, if I'm feeling now like I have to go, I'm not just going to go now. I'm going to go to the bathroom. I'm going to say, okay, time to go, go. So we walk, we sit, we relax. An impulse gets sent down the spinal cord saying, okay, we're in a good position. We can do this. The urethral sphincter, the pelvic floor muscle, relaxes. The bladder contracts, and that's when it happens. So what happens when things go wrong? So for the purposes of this presentation, if your muscles aren't strong enough or don't have the endurance to hold back until you can get to the safe place, you're going to leak. That's the short of it. Your brain may say, wait till we get to the bathroom, wait till I get into the house, but your muscles can already be letting go if they're not strong enough. There's a few different types of urinary incontinence, and you may have heard of all the different types, but stress incontinence is when you cough, laugh, sneeze, lift, anything that increases the pressure in your abdomen. Basically on the top, so we're talking about the anatomy inside, you have your diaphragm on the top, super strong. Around the middle, you have your abdominal muscles, your back muscles, again, pretty super strong. And then on the bottom, it's just your pelvic floor. So if that's the weakest point, if you think about me squeezing, everything's going to go down. Not going to go up or to the sides. Very, very strong. That's my little funny picture. I like to throw cartoons every once in a while. Urge incontinence is that feeling that you have to go now. I gotta go, I can't wait. If I don't get to a bathroom, we're gonna be in trouble. Typically that's a diet, not only a function of a weak pelvic floor, but also a dietary issue. So you're consuming things that irritate the bladder, anything that's acidic or caffeinated, citrus, artificial sweeteners, things like that, not enough water, will cause the bladder to be irritated, and the bladder's like, I don't like that, I need to contract now. And again, you're crossing your fingers that you're in the right place at the right time. So can you hold long enough to get to the bathroom? Frequency. That is urinating more than 8 times a day. It's always shocking to me when I ask patients when they come in, how often are you going throughout the day? Oh, I don't know, every 1 or 2 hours. And they think that that's normal, that that's okay to be doing that. So if you're wondering if you're going to the bathroom too often, just count how many times during the day. And also during the night, so we call it nocturia, and that's getting up in the middle of the night. 1 time as you get older is acceptable, but any more than that we can really work on fixing that. And especially because it disrupts your sleep, disrupts all those things that we already talked about, so you wake up tired and groggy and stressed, and and then you don't want to exercise. You can also have mixed incontinence, which could be a combination of any of those 3. Let's see. So how do we get a pelvic floor dysfunction? How does that just happen to us one day or not? So there are 2 ways that the pelvic floor can cause issues, by being underactive or overactive. So in simplest terms, you can think of being underactive as an underactive pelvic floor as being weak or overstretched. And that can be caused by things like childbirth, obviously advanced age, you got that decreased estrogen, high BMI, being on long-term oral estrogen, diabetes, decreased overall mobility, which again is going to give you that high BMI likely, constipation or frequent straining, heavy lifting. And those are the things that lead to urinary incontinence and pelvic organ prolapse. So that's that underactive pelvic floor. This is the nicest picture on the internet I could find of what a pelvic organ prolapse looks like. If you want to see actual anatomy, it's pretty scary, but you can Google that. So a pelvic organ prolapse is a condition where the structures, such as the uterus, the rectum, the bladder, urethra, small bowel, or the vagina itself can begin to prolapse or fall out of the normal positions and kind of push through the vaginal wall, and you can actually sometimes, depending on the grade, can see or feel one of those organs. It's the vaginal wall that you feel, not the actual organ, but you'll feel that bulge. And we classify them based on what structures fall in, whether it's a uterocele, which is the uterus, cystocele is the bladder, rectocele. I don't know if any of you have heard of those diagnoses, but it depends on what structure is falling through. So these things have a pretty significant impact on your quality of life and your self-perception of your body image. And it really leads to decreased activity and decreased exercise. So the overactive pelvic floor is usually, so again, typically a muscle that has difficulty relaxing. So opposite of what would cause urinary incontinence or pelvic organ prolapse, we're talking about a muscle that's hyperactive. So it could be a spasm, it could be from scar tissue, and some things that can cause the overactive pelvic floor, bowel and bladder disorders, interstitial cystitis, irritable bowel syndrome, endometriosis, any physical or emotional abuse. Again, a lot of times with emotional things, we don't always hold our tension in our necks or our backs. Sometimes people are holding it in their pelvic floor. Any childbirth or surgical traumas, and these can lead to diagnoses such as levator ani syndrome, vaginismus, chronic pelvic pain, and again, sexual dysfunction. So what does that mean for us for every day? Who knows where the bathroom is in every grocery store, or department stores, or on the highway even? Which are the best rest stops on 95? I don't know. We can limit travel because of that. If we're not sure, we're traveling from here to Provincetown, well, where's a clean bathroom? I'm not sure, I'm just not gonna go. Or if your bunch of friends are going out, oh no, I'm just, feel uncomfortable. We can be embarrassed about having the odor or wetness, always having to have a change of clothes with us. So that can limit a lot of functional activity. We also maybe just walking the dog. I have a lot of patients who just taking that couple miles around the neighborhood, and they'll come back and they'll have to go before they even get back into the door. So some people just stop doing that, stop going to exercise class, stop jumping on the trampoline with their kids or their grandkids. So incontinence and prolapse can really change how we live our lives and how we can get some exercise and some movement. So what can we do about it? First, you want to talk to your doctor. They want to rule out anything medical. If you're someone who wants to take some medicine, they can prescribe that. A lot of those medicines have side effects, and I found that a lot of my patients do not prefer that. But you want to talk to your doctor first, just to rule out anything. Second thing, or first thing I would do, is ask for a referral for physical therapy. I believe that I am still one of only 2 or 3 people on the Cape, therapists that treat this. So, you definitely want to find a pelvic floor therapist in the area to treat it, because not every therapist is qualified to treat this area. But I get this question all the time, like physical therapy for lady parts, like what do you do there? So we've been talking about bones and muscles and joints and ligaments, connective tissue, and that's what PTs do. These happen to be internal, but we are the specialists in musculoskeletal dysfunction. So we deal with bones and joints and muscles and connective tissue in all parts of the body. So yes, PT for pelvic floor. So it's a specialty, and we focus on dysfunctions of the pelvis, primarily. And that's just what we just said. Okay. So what do we do when you come to see a therapist? You make an appointment. Typically, patients call me and say, what are you going to do? How do we fix this? So we do what we do with any patient, really do a comprehensive evaluation. We'll check the pelvis, make sure that everything's in alignment, because things can't work if they're not lined up. We do a hip muscle assessment. We'll check the your neurologic integrity, make sure that your brain and your nerves are connected to those muscles still so that they can work. A perineum assessment, and we include tissue integrity, location of pain if you're having pain, a very comprehensive pelvic floor muscle exam. If you're coming in for pain, we look for trigger points, and we talk a lot about diet and fluid intake. So treatments are always based on individual findings. People ask me all the time, well, can I just do Kegels? Can I just do this? And I really can't tell you what you can do specifically until I find out specifically what your issues are and what we need to work on. Maybe you have to learn to relax the muscles before you can strengthen them, or maybe they're overworking and we need to work on that, or maybe they're just not working at all and you can't figure out where are those pelvic floor muscles. That's the kind of assessment we do. So don't go online and read about doing 100 Kegels a day, because I can tell you that's going to make you tired, and it's just not going to be effective. You're pretty much going to be wasting your time. If you go to the gym, if you're 20 years old and you go to the gym, you're not going to do the same exercise program as a 50-year-old or an 80-year-old going to the gym. It's all got to be specific so that you get the most bang for your buck and your time spent doing those exercises. You could be doing the exercises incorrectly. You don't know how many patients I have that come in and say, oh yeah, I've been doing these for years. And then I ask them to do it, and they're not doing anything even close to what they should be doing. So it takes a lot of time to really educate and really find those muscles and decide to what we're gonna work on. Doctors don't have the time generally. They can do a quick assessment and say, oh yeah, this is what you need to do, but they don't really take the time to, not they don't take the time, they don't have the time in their very busy schedule. We just heard from Dr. Thompson, who said she would want to do, all this education, but they're very limited on their time that they're given with patients. So I am lucky enough as a therapist to have that time to really figure out what's going on, teach you what you need to do, spend the time. If you can't get it, that's what we do. We spend the time so that you can get it, and then give you exercises to do at home. We use biofeedback. We use electric stimulation if you're having difficulty. We do a lot of manual techniques, definitely home exercises, because that's the key, is doing it yourself. There's no magic pill that we could give you to make it all better. We talk a lot about diet and a lot of education. And so it can be a part of aging, and we do see it a lot, but it was definitely something that we can do about it if you